If you are preparing for the AANP or ANCC PMHNP certification exam, serotonin pharmacology is one of those topics you absolutely need to recognize clinically, not just memorize. On boards, serotonin usually shows up through antidepressant mechanisms, adverse effects, drug interactions, receptor activity, serotonin syndrome, and the key differential diagnosis, neuroleptic malignant syndrome. Start with the basic anchor. SSRIs inhibit the serotonin transporter, or SERT. That means they block serotonin reuptake and increase serotonin in the synaptic cleft. If the answer choice says blocks reuptake of serotonin, that is your SSRI mechanism. Common SSRI adverse effects include GI upset, nausea, diarrhea, headache, sweating, insomnia or sedation, anxiety or restlessness early in treatment, weight changes, and sexual dysfunction. On exams, sexual dysfunction and GI effects are especially high yield. Also remember the boxed warning. Antidepressants can increase suicidal thoughts and behaviors in children, adolescents, and young adults up to age 25, especially early in treatment or after dose changes. Now, the most important serotonin emergency is serotonin syndrome. This is medication-induced toxicity from too much serotonergic activity. The classic triad is mental status change, autonomic instability, and neuromuscular excitation. Think agitation, confusion, fever, diaphoresis, tachycardia, hypertension, diarrhea, tremor, hyperreflexia, and clonus. Clonus is the board buzzword. If you see inducible clonus, spontaneous clonus, or ocular clonus after a serotonergic medication change, think serotonin syndrome. The onset is usually rapid, often within hours of adding a serotonergic drug, increasing a dose, overdose, or combining interacting medications. High-risk combinations include SSRIs or SNRIs with MAOIs, linezolid, tramadol, meperidine, fentanyl, stimulants, triptans, lithium, St. John's wort, or multiple antidepressants. The first action is to stop the offending serotonergic medication, then provide supportive care, fluids, cooling if hyperthermic, and benzodiazepines for agitation or tremor. Cyproheptadine, a serotonin antagonist, may be used when symptoms are moderate to severe or not improving. Now, separate serotonin syndrome from neuroleptic malignant syndrome. Serotonin syndrome is fast, serotonergic, and hyperactive. Clonus, hyperreflexia, tremor, diarrhea. NMS is slower, usually after dopamine antagonist exposure, and has severe lead pipe rigidity, bradyreflexia, fever, altered mental status, and elevated creatine kinase. Board shortcut: clonus equals serotonin syndrome. Lead pipe rigidity equals NMS. Also, no receptor-targeted drugs. Buspirone is a 5-HT1A partial agonist used for generalized anxiety and is not a benzodiazepine. Trazodone blocks 5-HT2A and is often tested for sedation and priapism. Mirtazapine enhances serotonin and norepinephrine release and blocks 5-HT2 and 5-HT3, helping explain less sexual dysfunction, more sedation, increased appetite, and weight gain. Ondansetron blocks 5-HT3 and treats nausea. For boards, always ask, what serotonergic drug was started? What interaction occurred? Is there clonus or rigidity? And what is the safest first action?